Good afternoon and welcome to the webinar. This is our part 3 of our Reducing Your Risk of Heart Disease webinar series. It is blood pressure control to reduce your risk of a second event. I am giving everyone a quick moment to sign on, and we will get started momentarily. Everybody is in listen-only mode. My name is Andrea Baer, and I will be the moderator for the webinar. Today, we are excited to be able to present to you the topic with Dr. Darmesh Patel. Dr. Patel is a practicing cardiologist at the Stern Cardiovascular Foundation. He holds board certifications in internal medicine, cardiology, hypertension, echocardiography, nuclear cardiology, and is a diplomat of the clinical lipidology and vascular interpretation. Special interests include preventive cardiology, hypertension, and lipidology. He is involved in the Stern Cardiovascular Foundation, Specialist Clinical Hypertension, American Society of Hypertension, President of the Alliance for Patient Access, past American Heart Association President, and past chairman of the Medicine Baptist DeSoto Hospital, and a board member of the AHA Southeast America. Marlyn Taylor is also joining us. He is the regional director, Western Regional Director-elect for Mended Hearts, and he has served as his chapter's president for 6 years and has been a secretary for 2. He has also been a regional director, assistant regional director for 8 years, and has helped start 5 new chapters in the Washington and Oregon areas during his time. He is also a patient, so he will be speaking today from a patient perspective. Just a few things before we begin. As I said earlier, everybody is in listen-only mode. We will hold all of our questions until both presenters have finished their presentations, and then we will go into the question and answer period. During that time, you can ask a question in 2 ways. One, you can type it into your chat box, and I will read the question out loud to the presenters. Or you can raise your hand by clicking the little hand button that is in the box by your name, and that will alert me that you have raised your hand and you would like to ask a question. Then I can unmute you and you can ask your question. So before I turn it over to the presenters, I just wanted to give you a little bit of background on the 2 organizations who are bringing this to you today. Mended Hearts is the largest peer-to-peer support network in the world, and our mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We have 285 chapters across the country serving 460 hospitals. And the American Society for Preventive Cardiology mission statement is to promote the prevention of cardiovascular disease, advocate for the preservation of cardiovascular health, and disseminate high-quality evidence-based information through the education of healthcare clinicians and their patients. And we're so very thankful that you're joining us today. And now I'm going to turn the presentation over to Dr. Patel. Dr. Patel, the floor is yours.
Good morning and good afternoon to everybody. It's an honor to be presenting for the Mended Hearts. And really, we are talking about an extremely common disease state, irrelevant of what kind of medicine you practice or what kind of patient you are. Hypertension certainly is something that's going to be hard to avoid. And the reason I say that is because you can look at the facts. You know, 2/3 of America over the age of 65 has hypertension, 50% of patients over the age of 50 have hypertension. Unfortunately, as we age, I like to call it, our pipes start stiffening and blood pressure does become an issue. And this is a pretty amazing fact. Adults age 45, their 40-year risk of developing hypertension is 93% in Afro-Americans, 92% in Hispanics, and 86% in whites. So the point is, blood pressure is an issue, an extremely common disease state. And our last guidelines were actually in 2003, when we talked about the JN7 guidelines. We now have guidelines that came out in 2017, And the exciting thing about these guidelines are it was a universal approach from many different associations and organizations bringing the 2017 guidelines. And, you know, I want to just start off by saying, why is hypertension so important? Hypertension is so important because if you lower hypertension, you reduce the risk of a heart attack by about 25%. You reduce the risk of a stroke by about 30 to 40%. And more importantly, you reduce the risk of heart failure by up to 50%. And all of you are aware, heart failure is the #1 DRG diagnosis in America. So yes, hypertension does prevent strokes, but in my field, heart failure is just as important. And another point is, well, the guidelines have definitely changed, and some of the guideline changes I'm going to show you some of those JNCA main points later on, but as you can see, as I go through my discussion, you will see that there are some changes that have occurred in the guidelines and in the goals. I think the most striking thing that I'll show you later on is that patients with proven atherosclerotic cardiovascular disease, we want their blood pressure to be 130/80 or less. In the last guidelines, it was 140/90, and it does make a difference. We know that when the systolic blood pressure goes up 20/10 higher than the aim goal, you double your risk of a stroke or an event. So in summary, someone that needs a blood pressure of 120 and their blood pressure systolic is 160, you actually have a 4-fold increased risk of cardiovascular events simply because the blood pressure has doubled twice. Now, that being said, I'm going to go through some slides and talk to you about some of the main highlights of the JNCA guidelines. And my next slide after this is going to talk about the trials that made these changes. So kind of the next slide. Next slide really just gives you an understanding of the complexity of hypertension. You know, there are different factors that are taken into account: sodium, potassium, obesity, genetics, and also social determinants. You know, I'm very heavily involved with patient care access. And of course, unfortunately, patients don't take their medicines like they ought to due to many reasons. So I just thought this slide was nice to give us a real world reasoning of why patients do have high blood pressure. Next slide. This slide talks about the trial that really, I think, changed our approach to hypertension. And this is the reason why in 2017, the guidelines slightly changed. They made those goals much more stringent. And the reason is because of the SPRINT trial, the Systolic Blood Pressure Prevention Intervention trial. And this trial was a really large trial, and it showed that intensive treatment of blood pressure, i.e. keeping the blood pressure in the 120s, actually did have further added benefit. In fact, it lowered cardiovascular events by 25%, and this was really important. It reduced all-cause mortality by 27%. So in summary, the SPRINT trial, I think, was the trigger to why the guidelines changed and why the guidelines became more stringent. Next slide, please. So as I mentioned, the 2017 guidelines about a year and a half ago now came out, and it was really important because this was one of the guidelines where most societies came together, all different types of societies, and they agreed on guidelines. So I just gives you a real nice list of the organizations involved, including ACC, Black Cardiology Association, and Preventive Cardiovascular Nurse Association. So it was really all kinds of organizations, and I really think that's important to say. Next slide. So this is the nuts and bolts of the new definition of blood pressure. And these slides are basically taken from the ACC 2017 guidelines. You can clearly see here the categories: normal blood pressure 120/80 or less. Now remember, elevated is now 120 to 129. Stage 1 hypertension is 130 to 139/80/89, and stage 2 is 140/90. Now, one point I want to make very clear, as I mentioned before, if someone has stage 2 hypertension, they probably need combination therapy. Monotherapy will not be suffice. Next slide, please. And of course, when you talk about hypertension, there are other causes of hypertension that must be thought about. You know, if you have a very young lady, for example, you may need to consider renal artery stenosis or fibromuscular dysplasia. So you have to be very careful not to just put these patients on medicines and try to understand there could be an underlying cause. One point I want to make very, very clear is sleep apnea is the #1 cause of secondary hypertension. Sleep apnea is patients who basically sleep at night, they don't get enough oxygen, they have increased oxidative stress, they have apneic spells, they're essentially drowning when they sleep, and this triggers blood pressure spikes. So if you see a patient who has blood pressure spikes, there's a very good chance they have sleep apnea. In fact, sleep apnea is probably one of the most underdiagnosed therapies out there. And if someone has resistant hypertension, that is, patients that are taking 3 antihypertensives, you must be sure that you consider sleep apnea as a probable workup for a cause of hypertension. Now, you can see, of course, there are other causes of hypertension. I always like to make sure my patients are not taking non-steroidals. I'd like to make sure they don't drink alcohol. And then there's some rarer causes that I've shown you in the bottom slide, just for time's keeps. You know, these other uncommon causes are things that you must consider, especially if you have a difficult time controlling their blood pressure. Next slide, please. And so, again, this is just showing you what things are common out there in terms of when you look at the other causes of hypertension. I think it's important to say that patients that have renal disease, patients who have a GFR less than 40, usually those patients will need a loop diuretic to treat their hypertension. Next slide, please. And so with that being said, you know, it's very important when you approach these patients to certainly talk about non-pharmacological initiation first, lifestyle changes. And yes, even a very small reduction in weight can actually reflect a reduction in cardiovascular events. The DASH diet, low in salt, high in grains and fruits, you can see here the impact of these remedies on hypertension. Generally speaking, all of these things will reduce your systolic blood pressure 3 to 5 points respectively each. Reduced sodium intake is very important, and also a good amount of potassium. Diets rich in potassium would be very useful too, such as bananas or maybe orange juice, let's say. But the point being, lifestyle changes do make a difference. Next slide, please. And with that being said, exercise is key too, and alcohol. You know, we only suggest 1 unit per day. Alcohol is very important to restrict and control. Exercise, I think, is key. As you can see here very nicely, the reduction in systolic and diastolic blood pressures, systolic blood pressures with exercise, you can see an average of 8 to 5 millimeters of reduction. So in summary, all these different modalities reduce systolic blood pressure by approximately 3 to 5 millimeters each. So if you are a person that smokes and eats salt and doesn't exercise and all those bad things, well, there's a potential that you can lower their blood pressure 15 points alone simply by just lifestyle changes. Next slide, please. So this is the classification of blood pressure. As I mentioned, the new change here is it is defined as elevated if your blood pressure is 120 to 129. That is defined as elevated, and then you have stage 1 and stage 2 hypertension as shown here respectively. Next slide, please. The key is, though, this is interesting, the number of patients who have hypertension now as per the new guidelines is higher. There's a 13% increase. And remember, as I mentioned, you know, the guidelines do say 130 over 80 for higher risk patients, but there are people in that 130 to 139 range who have a ACC cardiovascular risk of less than 10%, who can initially try lifestyle changes first. They don't need pharmacokinetic therapy first. Next slide, please. And it's important when you talk about the treatment of high blood pressure, we must start off with lifestyle first. But the difference here is, you know, they want a much more rigorous follow-up, especially if your blood pressure is stage 1 or stage 2. In my practice, I see them within 2 to 4 weeks, depending on what the quote baseline blood pressure is. And as I mentioned, most patients who are higher risk cardiovascular patients will need some kind of medical therapy, especially if they're stage 1 or stage 2 hypertension, respectively. Next slide, please. One thing that's very, very important to remember is patients who have no known CVD and who have a risk of less than 10%, you only start pharmacokinetic therapy if their blood pressure is 140/90. Now, patients who have heart disease, stents, bypass surgery, strokes, you want their target blood pressure to be around 120/80, which is a new definition, a new target compared to the old guidelines. Next slide, please. One thing that's so key is when you are checking blood pressures, you must use the right cuff size. Patients who have big forearms, muscular patients, will certainly need a bigger cuff. And more importantly, another point I want to make is you do not just judge all your readings on one simple office blood pressure reading. Next slide, please. The guidelines say you should have at least 2 readings on 2 separate occasions. I have my patients sitting there, have their arm relaxed. I use the appropriate techniques. I use the right cuff size. I make sure they're a bit relaxed, and ideally I wait for a minute or 2 once they get into the room. You know, we check the blood pressures, and I always ask the patient to write their blood pressures on a piece of paper and give me some blood pressures from home. Sometimes there's questions about the blood pressure machine. I say, well, bring your blood pressure machine in with you next time and we can calibrate accordingly. So this is very key. Next slide, please. Because what happens is patients can have, as you well know, they can have white coat hypertension where their blood pressure is high at the office and lower normal at home, and you can have the patient that has masked hypertension, the patient that has a normal blood pressure in the office, but it's very high at home. And you can understand both ways why that could be. Some patients are more stressed in the doctor's office. Some patients have more stress at home. So it's very difficult to just do all your recommendations on one reading. I think you need a series of readings, and it's been very clearly shown that ambulatory blood pressures, recordings from ambulatory blood pressures are much more superior than simply taking a couple of blood pressures here and there. So if you do see a patient with high blood pressure or primary hypertension, there are some simple things that you would recommend, such as the lipid profile to give you cardiovascular risk. The calcium might be important. For example, let's say if they had hyperparathyroidism, TSH can affect blood pressure. A urine analysis, look for end organ damage, look for microalbuminuria, look at the EKG, make sure there's no evidence of left ventricular hypertrophy. These are all things that can be helpful in a patient that has hypertension. Next slide, please. And this is just a slide in a different format. Next slide, please. So as I mentioned, when you use the ambulatory blood pressure monitor, I think this is really the standard of care, I would say now, using ambulatory blood pressures to check your blood pressure. You know, there are different thresholds in terms of daytime blood pressure, nighttime blood pressure, and average blood pressure. So I definitely use ambulatory blood pressures in lots of patients who have, quote, labile hypertension, etc., etc. Next slide, please. And, you know, the principles of the antihypertensive therapy is, you know, when lifestyle does not improve, which, to be quite honest with you, most patients don't improve on lifestyle, I follow them up every 4 to 6 weeks, and I check them until their blood pressure is controlled. And it is very important to understand that when you treat blood pressure promptly and quickly, you actually do reduce cardiovascular events. There are many trials that have shown intensive therapy of blood pressure, quick follow-ups, patients do better because, of course, their risk is reduced, of course, too, when you are much more aggressive. Next slide, please. Now, when you're talking about the antihypertensive, certainly you want to talk about the patient and the pros and the cons. If I have an Afro-American patient, if I have an elderly patient, and you consider thiazides, I think thiazides are good options in Afro-American patients. I think calcium channel blockers are good options in Afro-American patients, but you have to understand you can get gout, and thiazides could certainly cause hyponatremia in elderly patients. I always use ACE or ARBs in my MI, heart failure, diabetic patients. Remember, ACE ARBs have been shown to be beneficial and reduce mortality in heart failure patients. Remember that ACE-ARBs have been shown to reduce the progression of renal nephropathy. We know from trials like HOPE that post-MI patients who were diabetic did better with ACE inhibitors. So there is a vast amount of information for using ACE and ARBs. Of course, you never want to use an ACE or an ARB in a potential lady who may be thinking about getting pregnant, or someone has hyperkalemia, and also someone that has renal artery stenosis. Remember, if you give a patient ACE or ARBs and their creatinine jumps up, it could be the first clue that the patient has renal artery stenosis. Of course, calcium channel blockers would be a preferred option in elderly patients and Afro-American patients. 12% of the time you can have leg edema. So sometimes if someone has leg edema with, let's say, amlodipine, I may actually add an ACE or an ARB to cause both pre-capillary and post-capillary dilation, hence the edema can get better. Beta blockers, I think, are very key in post-MI patients and post-heart failure angina patients. Of course, you want to be careful in COPD patients. You do not want to exacerbate bronchospasm. So in those cases, you might use simply a beta-1 selective one, such as, let's say, atenolol or nebivolol. Next slide, please. So in summary, I want to just end up by saying, you know, how the guidelines have changed. If you had a patient who's had known CVD, the guidelines are much more stringent. You want to keep their blood pressure in the 120/80s. Someone who has stage 1 hypertension, you want to keep that blood pressure less than 130 ideally. We definitely define hypertension stage 2 as 140/90. And so it depends on the patient, but most patients should either get ACE, ARB, calcium channel blockers, or thiazides as initial therapy for blood pressure control. Afro-American patients, I think thiazides and calcium channel blockers. And patients with kidney disease, you want to consider ACE or ARBs. And of course, one big misconception is just because the creatinine is elevated, it does not mean that you should not start an ACE or an ARB. As long as the creatinine doesn't jump above 30 to 40% of baseline and there is no hyperkalemia, there is no reason why you would not continue that in that patient too. Next slide, please. So this is a very nice go-to slide when you're practicing out there in the trenches, looking at the different types of patients that I've described today. The patient who has ASVCD, who's had CAD or a stroke, or had a AAA or PVD, let's say, you know, I would like to keep their blood pressure in the 120/80s, as the goal says on the right side. A patient who has a risk of less than 10%, you can get away with a blood pressure of 140/90 or less. Elderly patients, you know, the goal is to keep the systolic less than 130. And then you have all these different disease states: diabetics, chronic kidney disease, heart failure, stable ischemic heart disease, stroke prevention, PAD. In summary, these subsets should really try to keep their blood pressure systolic in the 120s. That's your goal. And that's definitely a big difference compared to the guidelines before, which set up less than 140/90. So to me, that's the biggest take-home point in terms of blood pressure goal changes. And, you know, I want to end up with the last slide here. Well, sorry, 2 more slides. This is just another way of, just if you go back 1 slide, this is just another way of summarizing what I've mentioned. And now to the last slide, talking about, you know, hypertension generally. This is a very nice, realistic flow sheet of what we should be doing to treat patients with hypertension. We get their blood pressure. We make sure we're not getting a white coat hypertension or a masked hypertension patient. Think about secondary causes of hypertension. Remember what I said today. Patients who have sleep apnea, kidney failure, hyperaldosteronism. These are all kinds of patients that we need to identify. Patients who have end organ damage like microalbuminuria or eye damage, or patients who are getting close to dialysis. These are patients who really need to have their blood pressure controlled. Of course, we want to talk about lifestyle changes first, but a lot of our patients are beyond, quote, lifestyle, unfortunately. You can use the ASVC risk estimation to figure out what their risk is. If their AS species risk is greater than 10%, you may want to be a bit more aggressive. You want to align your treatment options depending on the age, the race, the ethnicity. You will start therapy. You will make sure they get appropriate follow-up. And remember, this is a team approach. It starts with the medical assistant taking the blood pressure once or twice, and then the mid-care level providers and doctors all together, nursing triage nurses, home health nurses, insurance companies checking the blood pressures on the patients at home. It's a team-based approach because this is the way that we can get their blood pressure down. We have to be able to detect and reverse non-adherence. And really the bottom line is this, to me, is a very, very preventable disease state if we educate our patients appropriately. So with that, I think that's a nice summary, and I've spent my time is up 25 minutes. I just wanted to give everybody on the line a brief introduction into the nuances of the new guidelines in 2017. And I kind of want to end up with, I'm going to take your blood pressure, so try to relax and not think about what a high reading might mean for your chances of living a long, healthy life. So hypertension, I always tell my patients this very last thing, when you have high blood pressure, you feel fine. But if you have a stroke, it's over. So check your blood pressure. It's the silent killer. So with that, I'd like to give it back to Andrea to continue the webinar. Thank you very much.
Thank you very much, Dr. Patel. That was a very great overview of treating high blood pressure, and we appreciate your insight. Now I'm going to turn it over to Marlyn Taylor, who will talk from a patient perspective, share a little bit of his story and his tips on managing blood pressure control from a patient perspective. Marlyn?
Hello. Thank you for giving me the opportunity to talk about my experience with high blood pressure and the efforts that I have made to control it. I have been diagnosed with essential hypertension, and what that means is that I fall into a cohort of hypertension patients with blood pressure readings that are classified as high hypertension stage 2. And as we heard from Dr. Patel, that is a systolic reading of 140 and above and a diastolic reading of 90 and above. We live in an age where it's pretty easy to find out what your blood pressure is. Next slide. There are many common places that you can find this out. Many years ago, this didn't happen, but one day when I was having my teeth cleaned at the dentist's office, the hygienist took my blood pressure, and I thought that was rather unique. When I went for my eye exam, I found out that they took my blood pressure again, so that's another place of finding out. And then, of course, we've all been to a hospital lobby and found the complimentary blood pressure checks, and into a drugstore where you find the machines that will take your blood pressure. Interestingly, the blood pressure machines that they have there now are much more sophisticated, and they will be able to take your body mass index, weigh you, and if you sign up, send you an email and tell you what it is. If you go in regularly, it's one way of charting. I personally take my blood pressure, as Dr. Patel suggested, twice in the morning and average that for my reading, and then record it. I do this diligently. And of course, the last place that you find that you can have your blood pressure checked is at the doctor's office for an annual visit or checkup. Next slide. How I found out about my high blood pressure was that I gave blood regularly, about every 6 weeks or so, and all went really well as I accumulated credits for the amount of blood that I gave. I felt good about all of that. One time the person taking my blood pressure said, "Do you know that your blood pressure is a little high?" And I said, "No." I should have done something about it then. I should have gone to a doctor, but I was young and dumb, and I continued on my way and lived my life as though nothing had happened. But one day I went in to have to give blood, and the person said, "Your blood pressure is too high. You can't give blood today." And that meant that I had a systolic reading of over 180. That is when I finally made that doctor's appointment. At the doctor's appointment, it was recommended that I start on a medication regimen, and I agreed. And I can tell you that the medications helped. Next slide. And this is was my first line of defense. And the medications did help. I went from an average of 180 over 72 to an average of 155 over 77. So I can tell you that definitely the medications help. But 155 over 77 was not all that good. So that's when I employed the next tactic, and that was diet. My daughter suggested that I make a big change to my diet, and she cared enough that she volunteered to go on a juice fast with me. A nutritionalist concocted a balanced juice drink for us, and that is what we ate for 5 days. For the record, there was also a physician on the staff to monitor progress. So for 5 days, we drank a large glass of juice for breakfast, for lunch, and for dinner. Mine was vegetable juice with no carrots or fruit. That was because I was also a diabetic. The first day and the last day, the meals were made up of raw vegetables. The amazing thing to me was that because the drink was balanced nutritionally, we were never hungry. And the result of that was that my blood pressure dropped to a level that I was taken off blood pressure medications. And I was able to control blood pressure through the diet. After the intensive first week, I mostly followed a Mediterranean diet that was heavy in fruit and vegetables. I like raw vegetables, so many times I consumed them raw, and I ate very little meat. The diet did some additional things because it was heavy to vegetables. And fresh vegetables, it automatically cut down on the amount of salt I was ingesting. And that's one of the other lifestyle changes that Dr. Patel talked about, that lower blood pressure. And it controlled my glucose readings too, and all of that without medication at that point. I did that for better than a year, but then I slid backwards to the standard American diet, and the blood pressure began to rise again, and so did the glucose readings. And that put me back on medications. And that is when I tried tactic 3, exercise. When is the best time to exercise? That depends on your goal. And the goal today is lower blood pressure. In a new research in the journal Medicine and Science in sports and exercise, people who have hypertension performed moderate intensive exercise for 45 minutes 3 times a week for 10 weeks, either in the morning or evening. Those who exercise between 6 and 8 p.m. Saw a 8-point drop in systolic blood pressure, and that was on average, and that was compared to a control group who did not exercise. While the morning exercisers experienced a 5-point drop. I did a little experiment of my own just to test out the effect of exercise and blood pressure. And what I did was I took my normal blood pressure readings the first thing when I got up in the morning before I had taken my blood pressure meds. And then I took the meds and I walked for 30 to 40 minutes. This is what I found. My first reading on waking was 142/84. Why my blood pressure is high after resting and sleeping, I don't know the answer to that. After taking medications and walking for 30 to 40 minutes, my blood pressure was an average of 114/65. And one of the byproducts I found with exercise was that I started losing weight. I went from weighing 230 pounds to 214 now, and I'm not there yet. My goal is to get to 210 and 205 and 200 and finally to 195. I find that taking it in small increments and chunks works best for me because it's not nearly as overwhelming. So I'm not there yet. As far as my blood pressure, right now it's averaging 138/79. That is an improvement. So what else can I do? I'm on medication. I comply. I watch my diet, but I could do better there. The diet has led to lower salt intake, and exercise has led to weight reduction. I quit smoking 40 years ago, and my alcohol consumption is far less than the recommended 2 drinks per day for men. Heck, it's below the recommended for women of 1 drink per day. Have I touched on all of the lifestyles that lower blood pressure? Actually, I haven't. There is one more that I can think of. De-stress, relax, walk in nature, rest, meditate. What that looks like for me is to ditch the smartphone, the television, the radio, and the other distractions, and to start controlling my breathing. As I take a deep breath and hold it for a moment, and I breathe out, I tell myself that I am relaxed. I squeeze my hands tight, breathe in, and as I breathe out, tell myself that my hands, my arms, and shoulders are relaxed. By creating tension, then release it, I can feel that tension leave, and I can feel peace coming over my body. I tighten my legs, take a deep breath, and as I breathe out, I remind myself that my feet, legs, and torso are totally relaxed, and that I am at peace. As I continue to breathe slowly in and out, I concentrate on letting go of negative thoughts. When those thoughts refuse to go away, I try to replace them with the opposite positive image. Walking in nature is very peaceful and very beneficial. I think that you get more benefit from walking on the outside in a natural setting than you do inside the house. But exercise, there's an advantage either way. When it comes to meditation, relaxation, I haven't really taken my blood pressure very many times after I've used a guided meditation, but what I can tell you is that the times I have, it was definitely lower. And there are many guided meditations available for a person to use on apps. There's one called Simply Being. Then there's white noise background, which is designed to be very soothing. And one whose title I love, Meditation for the Fidgety Skeptics. And the other thing I have found is that laughter and humor can be great stress reducers. And having a key to remind yourself when you get uptight is really good. When I get tight or I start to get angry or something like that, I'll reach up and kind of scratch my nose, and it's my signal to me to remind me to lighten up. I heard a professional golfer talking the other day, and he said, I didn't win till I learned to control my breathing. And what I heard him say was that he had to slow down, calm down, release tension, control his stress, and to focus. For the best results, it's best to use all tactics. And when is the right time to start? Now. Thank you very much.
Thank you so much, Marlyn. What great advice. And I love that you gave practical solutions to some of the things that I know we all struggle with. So now we are at the question and answer period of the presentation. I will open the floor to questions. As I said earlier, you can type your question into the chat box and I will read it to the panelists to answer, or you can raise your hand by clicking on the little hand icon, and that will alert me that you'd like to be unmuted in order to answer your question. I know that we have a whole bunch of questions in the queue, so I will go through and try to give this to the panelists that I think might best be suited to answer, but please, both of you feel free to jump in on any of the questions that you feel you can give some answers to. The first question is, why is there no differential blood pressure guidelines for folks over 60? Dr. Patel, could you answer that?
Yeah, I think, there's been trials like the SHEP trial looking at systolic hypertension in elderly patients. I think, the irony is the patients who are elderly certainly still have increased risk of cardiovascular events, if not more. So I would challenge, why not have more stringent goals on elderly patients? Yes, practically wise, they can be challenging with either dips and peaks and troughs. I get it. But I feel that elderly patients should still have their goals the same as most other patients because of the disease process and the things it causes: heart failure, stroke, and heart attacks. So I think that they've got away from the differential, and I think elderly patients are at risk, if not increased risk, and I do not see a reason to make different, quote, guidelines for them. I do understand practically it can be challenging because of patients having variations in blood pressure, but for right now, we're treating patients generally, all of them, as the same.
Great, thank you very much. The next question is, can blood pressure be too low?
Yeah, it's not one of those things like cholesterol where we're finding out lower is better. We definitely know that there have been trials that have shown lowering blood pressure too much actually can have adverse effects too, obviously. There's actually a J-shaped curve, and yes, lowering blood pressure too much can be detrimental too. But remember, one or two patients you have to be careful about when you say that. If you have a patient that has, let's say, a reduced ejection fraction or cardiomyopathy, because the heart itself is not pumping as strong as a normal heart, let's say, you will end up with patients that have lower blood pressure. Now, when I have a patient that has an ejection fraction of 30% and their systolic blood pressure is 105/80, I'm not concerned as much, because as long as the patient is not symptomatic, that may, quote, be a normal blood pressure for them.
Great, thank you. So how often should I take my blood pressure at home?
I'm going to let Marlyn answer that question if you don't mind.
All right, Marlyn, how often?
How often should you take your blood pressure? Well, I think it kind of depends. I think that you want to get an average throughout the day. If I take my blood pressure before I exercise, right when I first get up, it's one thing. As I told you, when I take my blood pressure after I take my medications and exercise, it's another. And then if I take my blood pressure midday, that kind of gets me into the normal flow of life. And as I slow down at night, I take it again. I think that the doctor that I see likes to see those different changes. You could also discover patterns when that's going on, because you can say what was going on in the morning before I took that blood pressure at noon. Was I stressed out about something? Was my annoying brother still visiting after 3 days? And at that time, did I eat differently than I did before? So it gives you clues that may give you triggers of what you could do to better control your blood pressure.
Yes, and to Marlyn's point, I mean, you said it quite beautifully. You have to understand that blood pressure is not a flat line. It's a circadian type rhythm, kind of blood pressure range. It will go slightly high and slightly low. And that's why I tell patients check their blood pressures random times throughout the day.
Excellent. Thank you very much. Do you recommend wearing some kind of wearable device for monitoring blood pressure?
I would recommend it, especially when the diagnosis is not conclusive yet. And what kind of patients am I talking about? I'm talking about the patient who may, let's say, have white coat hypertension. The blood pressure they say is high in the office, but they say their, quote, blood pressure is low at home. I may consider in the patient whose blood pressure appears to be low at the office, yet it appears to be high on their blood pressure readings. I may consider in a patient who, let's say, is having a difficult time controlling blood pressure. You know, I might find out that their cuff is actually a completely wrong sized cuff. So there are so many different reasons for using an ambulatory blood pressure cuff, especially when you're not definitive on the diagnosis. But I've really found it helpful in those patients who have borderline hypertension in particular, because it tells you truly what their average is throughout a 24-hour period.
Excellent. Thank you. So the next question, what is more important, systolic or diastolic? And are there effects to blood pressure medications? And if so, how, hold on, I'm sorry. And if so, how do you manage them?
Yeah, a good question about systolic, diastolic. We know classically that when you're generally younger, diastolic blood pressure is an issue more related to the elastic recoil and elasticity of the artery. As we get older, i.e., let's say over 50, even though 50 is not old, as I'm getting close to that, systolic becomes more of a issue as the arteries stiffen more. The bottom line is systolic or diastolic, you should treat as per the guidelines. And certainly thiazides, calcium channel blockers, ACE/ARBs are not unreasonable options to treat either of these quote numbers. So it really depends on the patient again, you know, which kind of patient do we have and what might benefit them better when you're approaching the systolic or diastolic blood pressure. It may be someone that has leg edema or dyspnea might be better with the diuretic. Someone who has diabetes and renal dysfunction might be better with an ACE or an ARB. It all depends on the patient.
Excellent. Thank you very much. Okay, the next question is, with cardiovascular disease and type 2 diabetes, is it realistic to think I will ever be able to stop taking medication?
In summary, no. If you want the honest answer, it's going to be very difficult to say a cardiovascular patient, let's say a patient's got CAD and diabetes, had an MI, it's very unlikely that that patient is going to come off quote meds. We do know from the HOPE trial, even when patients had minimal changes in their blood pressure, ramipril or ACE inhibitors in that scenario still proved additive benefits of reducing further cardiovascular strokes, MI, heart attacks. So personally speaking, there's not very often a patient that has known established CVD, I am backing off on the medicine, unless we're talking about the patient that was 300 pounds that becomes 120 pounds. We may come off some medicines, but you have to understand, medicines like ACE and ARBs have benefits above and beyond just simply lowering blood pressure. They reduce nephropathy, they reduce eye disease progression, they help prevent strokes, heart attacks, they help with cardiac remodeling. So there are benefits above and beyond systolic blood pressure too, we think, and that's why it's usually very difficult to stop these medicines.
Great, thank you very much.
I would agree with that. The other thing that I have found is that, quite frankly, I don't have the strong discipline and willpower to go on a highly restrictive regimen of the 4 tactics or the 3 tactics that aren't on medication to allow me to get to that thing. So being human as I am, I find that medication is one of the key factors.
And to your point, Marlyn, only 3% of America practices the 7s of the American Heart Association, i.e. sleep right, exercise, diet, don't have diabetes, don't have high cholesterol, check your blood pressure. Only 3% of this country really does practice the fundamental guidelines by which we prevent or promote cardiovascular health. So your point is very well taken. I mean, realistically speaking, it is extremely difficult for most patients to keep with a lifestyle that will be, quote, maintained. So yes, the reality is patients need to stay on their medicines.
Thank you very much. So I have a couple more questions, and I think a few of them are fairly easy. One is, this is for Marlyn. After juicing, do you still feel hungry?
No, I didn't. And the key to that was that it was balanced nutritionally. So they made sure that I was getting all the nutritional value that I need, so my body wasn't craving that. And with the juicing, what I did was I drank very, very slowly. I took sips. And so that 16-ounce glass of juice I would do over a 1-hour period. And then the other thing was that I went somewhere to do this, so I was under the supervision of a doctor and a nutritionalist. And they provided educational classes to go along with it. So my mind was active, and I was busy doing something else. So I didn't have time to get that hunger craving.
Great, thank you. So this question I think is for Dr. Patel. It says, I've read about renal denervation for controlling resistant high blood pressure. Is that procedure going to become available?
Great question. There was the trial called the Simplicity trial looking at renal denervation as a potential mechanism of reducing blood pressure. And in summary, it was very promising, but it appeared that from the outcomes, it did not, quote, show the reduction in systolic blood pressures that we expected. Now, there are some flaws to the study. You have to understand it was very operator dependent. And what I mean by that is, skilled people denervating the renal artery, certain ways, certain techniques of denervation, and not everyone, I think, basically did it the same and practiced it the same. So the studies were basically not statistically significant. However, I think further trials are going on looking at renal denervation as we speak, and hopefully we can have some more information about this going forward. In Europe, it is used somewhat, but in America, as of right now, I do not think they have an FDA approval of renal denervation as we speak.
Great, thank you. So this question, I think, goes to both of you. If you could talk a little bit about side effects of blood pressure medications and how you're able to manage them. Maybe Marlyn can take the managing if there's any side effects.
Fortunately for me, the only problem I had was beta blockers, and that's because I had a heart rate in the high 40s and 50s, and so that was not functional, and I was just taking it off, and the ultimate conclusion was that a pacemaker would allow me to take that beta blocker to counter that side effect.
Great.
Yeah, good question. I think ACE-ARBs are known to be the antihypertensive group with the least side effect profile. And thereafter, you know, of course, I think calcium channel blockers are pretty well tolerated except for the 12% leg edema. Thiazides or diuretics are pretty well tolerated. You just have to be careful about electrolyte abnormalities and hyperkalemia. And last but not least, beta blockers. And as Marlyn has said, causes heart rate in some males. It can cause erectile dysfunction. So it's important to mention that. And, you know, in all these scenarios, we have to individualize the therapy for the patient. We are treating patients, not populations. So we have to do what's right for the patient. For Marlyn, beta blockers didn't work. Maybe ACE-ARB, calcium channel blocker, thiazides would be better options. So again, every action has a reaction, I suppose, to some extent. But we have to educate our patients about the known side effects. But generally speaking, ACE-ARBs have a very good side effect profile.
Great, thank you very much. So I just have one comment for Marlyn. The person says to please tell you that your examples and experiments were very helpful. And one last question we have, it's the question is, how does high blood pressure actually cause a heart attack?
I think high blood pressure is part of a whole RAS system, endothelial dysfunction, artery irritation, artery inflammation. It's not just simply a blood pressure phenomena. I think when you have high blood pressure, it affects other things. It affects, for example, left ventricular pressures. It affects the cardiac ischemia. It affects cardiac demand. And so indirectly, all this, quote, increased oxidative stress type phenomena will lead to plaque instability and plaque rupture. So in summary, I would say that hypertension is one of those substrates that causes heart attacks, but it's more than simply just systolic blood pressure. It's endothelial dysfunction, it's increase in interleukin 6, all these other things that are behind the scenes.
Great, thank you so much. And I just want to thank everybody for joining us today and for our two presenters. It was a great hour that we spent together. Our next webinar in the series happens on May 16th, and it is on the topic of preventative exercise and physical activity. All of the webinars are available and have been cataloged. If you all have missed any of the first three, you can feel free to watch them by going to our website under the Risk Reduction Webinar Series. They're also on YouTube. So for that, I am going to thank everybody for joining us again. If you need to reach out to us, feel free to do so. We're happy to help and answer questions along the way. And I wanted to give a thank you to our sponsor, Amgen Cardiovascular, who made these webinars possible along with an educational grant. So that is it for this week, and we appreciate you all spending your hour with us, and have a great day.